Okay, so good evening, and thank you for giving me this opportunity to be able to talk on the topic of adverse drug reactions to anti-tuberculose drugs in children. Sorry. Okay, so I have no disclosures for this lecture. And my objectives, so bear with me for the next 10 to 15 minutes, are the following. Okay. So adverse drug reactions, or ADRs, are defined as any harmful or unintended reaction to a drug which occurs at doses used for prevention, diagnosis, or treatment. In general, it is estimated that up to 15% of all drug administration would end up in an adverse drug reaction, and the risk is doubled in the hospital setting. It has been reported to account for 3 to 6% of all hospital admissions, and it would occur in 10 to 15% of hospitalized patients. More importantly is to note that fatal drug reactions can occur in approximately 0.1% of medical inpatients and 0.01% of surgical inpatients. Now, since this is an interactive lecture, let me start with my first question, a review of our pharmacology regarding adverse drug reactions, which is not a correct statement. A, dose-dependent and predictable adverse reactions are A-type ADRs. B, toxicity, side effects, and drug interaction. Okay, so key in your answers now. 5, 4, 3, 2, 1. May I see the result of the poll? Okay, so the answers are quite interesting, and we will see in the subsequent part of this lecture. So thank you for answering. So adverse drug reactions are either that of the A-type, which is dose-dependent and predictable, and exemplified by the following, or it can be that of the B-type, which is dose-independent and unpredictable, as shown by your hypersensitivity reactions, which can further be divided into your allergy. And as you know, this is divided into the 4 classic Gell-Coombs classification and the non-allergic adverse drug reactions. So drug allergy per se is an immunologically mediated response to a pharmacologic or formulation, which is the excipient agent in a sensitized person. It is estimated to account for 5 to 10% of all adverse drug reactions. So this is an updated picture of the 4 classifications from your Gell-Coombs. And if you take note, type 4 is divided into further 4 divisions based on the type of T cell that is involved in the reaction. Okay. Adverse drug reactions can also present as follows. So these are mechanisms that are unknown but presumed to be immunologic. Hence, the correct answer for the first question is actually letter B, because it is not type A. It is type A, and this the question is talking about the type B reaction. All of those are examples of type A. Moving on, these are the drugs used in the treatment of tuberculosis. The first-line drugs, as we all know, are those with greatest efficacy and acceptable degrees of toxicity and are used successfully in the great majority of cases. The second-line drugs are used in drug-resistant cases or those in which some other patient-related condition has compromised the effectiveness of the primary therapy. WHO classifies the adverse drug reactions to these medications mainly as side effects, and these are either minor, which doesn't need discontinuation of the drug, or major. There are factors noted to influence side effects of the treatment. So first is the age. We know for a fact that older patients are more at risk for hepatotoxic, nephrotoxic side effects, as well as the other side effects like those of balance and hearing loss. And when we have young patients, they're unable to communicate also sensory side effects such as reduced hearing, vision, or even peripheral neuropathy. Lifestyle, like those alcoholics, puts patients at risk further if they're given anti-TB treatment. And malnutrition and vitamin deficiencies also is another risk factor, as well as the presence of comorbidity, as you have heard, especially in adults with diabetes and children, all patients with HIV. So let's go on to the second question. Among the adverse drug reactions observed in children on anti-TB drugs, what is considered as a minor ADR? Please key in your answers now. 5, 4, 3, 2, and 1. May we see the poll? Okay, this is also very interesting. And you will see the answer later on as we go. So most of you said it's the itching generalized skin rash, which is minor. So moving on. So we do not have much data actually in our setting for a registry of ADRs to anti-TB medications in children. That is why it is highly encouraged that we report these adverse drug reactions to our therapeutics committee so that we can come up with our country's own registry for ADR to anti-TB drugs. But for articles that we have reviewed, the prevalence using the first-line drugs would range, the range is very far, no? It's between 8 to 85%, and for second-line drugs, it's 69 to 96%. The timing is noted mostly during the intensive phase more than the continuation phase, with some articles saying that it starts even at the 6th to the 42nd day of initiation of treatment. There was no difference in the frequency between a patient taking in the drugs intermittently or daily. And most of these reactions were noted to be minor, but more importantly, the ADRs can also be major in the form of hepatotoxicity, hence the term anti-tuberculosis drug-induced liver injury, ototoxicity, nephrotoxicity, and the like. Generalized rashes with mucosal involvement, such as your SJS, they are considered major. Hence, we need to discontinue the drug and at the same time admit these patients, and then meanwhile start substituting. The articles also mentioned or reviewed showed that the liver injury caused by these drugs were significantly associated with TB meningitis with a p-value of less than 0.01, hypoalbuminemia with a p-value of less than 0.05, and hepatotoxic co-medication intake with a p-value of less than 0.01. So moving on to the different anti-TB drugs, let us take a look at them. For isoniazid, ADRs would occur secondary to immunologic reactions, which may manifest as drug fever or drug-induced lupus erythematosus. However, direct toxicity is shown to be mostly the cause for major ADRs, such as hepatitis, which we shouldn't fail to recognize because it could be fatal in some patients. It can also reduce the metabolism of other drugs and substances such as phenytoin and tyramine, as we have seen in the previous lecture by the Western Visayas chapter, which leads to toxicity. Okay. For rifampicin, it may be classified as minor, such as the following. As we all know, it imparts an orange color to our urine, sweat, and even the contact lenses, and the manifestation of flu-like syndrome. Major manifestations could be involving drug-induced hepatitis, itching and generalized rashes, nephritis, thrombocytopenia presenting as petechial rash, and it strongly induces most cytochrome P40 isoforms, hence increasing elimination of other drugs. Adverse drug reaction to ethambutol may be minor, such as your arthralgias with peripheral neuropathy, but if it is major, it is said to be dose-related, presenting as retrobulbar neuritis, so patients may complain with loss of visual acuity, as well as red-green color blindness. Adverse drug reactions, meanwhile, to pyrazinamide can present minor as fever, joint pains, minor GR upset, nausea and vomiting, anorexia, and even abdominal pain. Take note that for major manifestations, again, the liver injury is there, together with confusion and hyperuricemia. The hyperuricemia is mostly seen in adult patients who have diabetes being treated also with anti-TB medications. And then for the second line or the drugs, such as your aminoglycosides, it is the adverse reactions are said to be major due to its toxicity and those related factors. So these are the manifestations. For your caprimycin, again, the manifestations are mostly psychiatric or neurologic, so personality changes, depression, and seizures can occur. For fluoroquinolones, we have the following. So they can have nausea, bloating, headaches, rarely tendon ruptures, but this can be treated with NSAIDs, but they can have also QTc prolongation as well as hypoglycemia. For prothionamide, these are the different manifestations. And again, you would take note of the major ADR, which is liver injury. But it will also have, it can also cause endocrine effects like as follows, and even neurotoxicity. For ethionamide, the adverse reactions are mostly GI upsets, but it can cause liver injury and hypothyroidism in some patients. And for cycloserine, these are mainly the manifestations. So it can be CNS, like lethargy, decreased concentration, personality changes, peripheral neuropathy, but there can also be dermal complications such as your lichenoid eruptions and even your Stevens-Johnson's. So next to the third question, what is the correct treatment statement regarding ADR to anti-TB meds? So please take time to read first. Sorry for the long sentences. Okay, and then please key in now your answer. 5, 4, 3, 2, and 1. Okay. So at least I am happier that most half of you get the correct answer. We'll see why in the next discussion. This is the last part already. So thank you for bearing with me. So diagnosis to ADRs to anti-TB meds would rarely have a use for in vivo and in vitro tests, as these are usually not useful and available. A high index of suspicion based on what we know about these drugs by itself, that this is the culprit agent when we withdraw it, is enough evidence that this is indeed the culprit agent or the cause of the reaction. So what are our treatment options? Managing the ADR is based on its mechanism. So if we are dealing with a drug allergy that is type 1, meaning IgE mediated, then there is no alternative available or equally beneficial drug to the patient, then the procedure called desensitization can be done. So how does it work? It aims to convert a patient who is highly allergic to that drug to a state where they can tolerate this drug. And in here, the muscles are rendered unresponsive to the drug. So I have to mention that when we do desensitization, it is only when there is no alternative drug available. And we do desensitization in a double setup because patients can go to your anaphylaxis. Another option is to do test dosing or graded challenge. So we do cautious administration of a medication to a patient who is unlikely to be truly allergic to it. However, we give it generally in very low doses. The starting dose is 110 to 100 of the full dose. Approximately 5-fold increasing doses are administered until the full therapeutic dose is reached. So in anti-TB medications, usually this we achieve this in 3 to 5 days. What is here is when it comes to hepatotoxicity, how do we introduce them? So you can see here that isoniazid plus rifampicin is more hepatotoxic than INH alone, more than pyrazinamide alone, more than rifampin alone, and more than ethionamide as to its liver injury capability. So that when we bring back these medications, we start usually with ethambutol followed by pyrazinamide, isoniazid, and rifampicin. However, more and more studies are coming up that it should be rifampicin that should be last, so we reversed it. So it's ethambutol, pyrazinamide, rifampicin, pyrazinamide, isoniazid, and then lastly is your rifampicin. And most patients will be able to tolerate it when we do the proper graded challenge. So treatment options, again, is discontinuation of the drugs. Consider skin testing if applicable and reliable, and this applies only for type 1 ADRs. Consider provocative dose challenge or desensitization. We give supportive treatments such as giving your NSAIDs for fever and joint pains. Adjust the timing of drug intake. So sometimes we have to deviate from the usual instruction. We give corticosteroids, and of course, during anaphylaxis, we have to give the drug of choice, which is epinephrine. So prevention is easier said than done in these TB patients because we do not always give the alternate, knowing that your first-line drugs are still the more effective drugs. Administer a potentially cross-reactive drug under medical supervision. Again, we can do provocative dose challenge. We can do pretreatment protocols. So this is when patients have minor manifestations, then we do treat through with antihistamines, for instance, if they just manifest with rashes, so that they will be able to tolerate their medication, and then perform desensitization only if there is no acceptable alternate drug. So thank you for bearing with this very long lecture series. That's it.